Our final chapter for Anatomy and Physiology 1 is about the autonomic nervous system, and this is a concept that's going to carry forward for the rest of your educational career. Understanding how the involuntary functions of the body work is going to be key to all kinds of things. It's going to play into pharmacology. It's going to play into every single one of our systems in anatomy and physiology too. It really never goes away as a concept. And though it's going to feel like a dense bit of information, really all of this information can fit onto one image. And I'll sort of try to illustrate that image for you as we go. So we've already been talking about the somatic nervous system, the voluntary, the conscious. Now we're going to talk about the autonomic, and as far as I'm concerned, you can go ahead and call it automatic. It's things that you don't physically have control over, and to an extent, some of that visceral sensorial stuff, where you don't really have a conscious awareness of it. You don't know what your acid-base balance is right now. You don't know what your carbon dioxide levels are right now, but your body does. And it's going to use some of that information, and it's going to utilize the autonomic nervous system to alter those states within your body without any of your consciousness. So the autonomic nervous system is divided into parasympathetic and sympathetic divisions. So we'll talk about how those divisions work. The names there are not intuitive names. You want sympathetic to be really calm and caring, but it's the opposite of that. So don't go intuitive on that one. And then how the central nervous system controls your autonomic functions, how it all works together. So with our somatic nervous system, you know that, for example, with your corticospinal tract, you have a lower motor neuron that's going to directly innervate a skeletal muscle so that you can do something that you decided to do, right? Consciously making the decision to flex my bicep and take you to the gun show, all that stuff. Whereas with the autonomic nervous system, we're going to have a little bit more complexity. We're going to have a couple of neurons in a circuit. We're actually going to have, from the spinal cord, one neuron that goes out to a ganglion and another neuron that goes out to a target organ. And that target organ is not going to be skeletal muscle or glands. It's going to be visceral organs, for example, or, again, glands. We can have glands there as well. So what this means is one neuron going to a ganglion, one neuron going to the target organ. We're going to call this neuron preganglionic, and we're going to call this neuron postganglionic. Do you guys remember the definition of a ganglion? Group of neuron cell bodies generally located where? Peripheral nervous system. Very well done. Okay, so autonomic nervous system is going to innervate smooth muscle, cardiac muscle, glands. Remember when we talked about muscle subtypes, and we said skeletal muscle is voluntary, whereas cardiac and smooth are involuntary. The difference is in how they are innervated. Okay, so we have preganglionic and postganglionic. For both of our divisions, sympathetic and parasympathetic, there will be ganglia. Their locations will differ where those ganglia are. Does the term preganglionic versus postganglionic make sense intuitively to you? Okay. So in general, if you want to really categorize the functions of these two different divisions, we'll say the parasympathetic division is the rest and digest system. It's going to slow things down. It's going to allow for digestion, so it's going to cause some vasodilation in the GI tract. It's going to be for bringing your heart rate down, breathing less. Whereas the sympathetic division we generally call fight or flight. It's going to increase your alertness, your metabolic activity. It's going to increase your heart rate, increase your breathing. It's going to dilate your pupils so that you can see everything. And the stereotype is so that you can run away from a bear, right? Or so that you can get out of danger, so that if you're in a fight in the pub, it's a fighting chance, basically. So these are the extremes, right? And the extremes will help you to remember it. As a sort of general concept, I want you to understand these things are always working. You're always in balance between fight or flight and rest and digest. It's just controlling your involuntary things. It's just teetering towards one direction or another. Hopefully you guys haven't activated. You're a little bit teetered towards parasympathetic right now. Maybe on test day it's going to teeter a little bit towards fight or flight, but hopefully not too far. We don't want you in like running from a bear mode while you're taking an exam. So this is sort of the beginning of that illustration I'm talking about in terms of how we can fit most of the information about the autonomic nervous system onto one picture. I just took a moment to start my illustration, how we're going to differentiate the parasympathetic versus the sympathetic nervous system. When we just started with this image of the brain, we're putting sympathetic to the right, we're putting parasympathetic to the left. We did include the brainstem. We included the spinal cord, and then I drew a set of actual ganglia to the right. And I only drew the ganglia to the right, unlike this image, which has it bilaterally. But I'm only putting sympathetic information on the right myself. So this image does have a lot of our starting information. It has some color coding here, where we have some parasympathetic nerves coming from the brainstem. And this is also going to have parasympathetic nerves coming from the sacral region. So we will call the parasympathetic division the cranial sacral division. Parasympathetic nervous system is coming from the cranial and sacral regions. And honestly, I'm just going to emphasize cranial, and I'll explain why later. Whereas our sympathetic division, this purple region, is going to be called thoracolumbar. So thoracic spinal cord here, lumbar spinal cord here, and most of your preganglionic neurons come from here. The thoracolumbar division of the spinal cord is the location that sympathetic nerves come from. Some of them are going to ascend, some of them are going to descend. We'll worry about that later. So parasympathetic, cranial, and in parentheses, sacral. Explain more why later. Sympathetic, thoracolumbar. And I'm going to put lumbar in parentheses too for you for a reason. So one thing I'm drawing only on the right side is this chain of ganglia. This has a name. This is the sympathetic chain ganglia. I know it's such an advanced naming convention, but it is a chain of ganglia. They are connected to each other in a chain. And this is located just anterior and lateral to the vertebral column, which is going to get us to our next concept. That in a sympathetic division, preganglionic neurons are short. And then when we need to get out to an organ, like the heart or the lungs, that postganglionic neuron is going to be long. So this is short, and this is long. Short to long. Whereas in the parasympathetic division, the preganglionic neurons are long, and the postganglionic neurons are short. In fact, the ganglia for the parasympathetic division will be located on or near target organs. Correct. On the parasympathetic division, the postganglionic neuron is short. It doesn't seem like the most significant thing right now, but this will have significance to you. You do need to know parasympathetic, preganglionic long, postganglionic short. Sympathetic, preganglionic short, postganglionic long. That's going to give you some of the characteristics of each of these divisions. It's also going to give you some anatomy. When we're in AMP2, we're going to see some things like the myenteric plexus. We're going to find some of these ganglia on or near those target organs. In the stomach, you actually have ganglia within the wall of the stomach, and that's going to help you with stomach motility for your rest and digest system. So some of that's going to be very related to the form and function of the autonomic nervous system. We're going to come back and see this concept when we discuss those things. The other thing it gets us for the sympathetic division is because those preganglionic are short, they're all synapsing in the sympathetic chain, they're going to be connected to each other. So which one was the sympathetic division? Was it rest and digest, or was it fight or flight? Sympathetic, fight or flight. I know it's not intuitive. That's why I'm asking. I'm trying to catch you guys before you make that mistake. Okay, so the sympathetic division is fight or flight. If we need to run away from a bear, we need all hands on deck, right? So by having these in one chain, communicating with each other, that means if one of these things gets activated, all of these things get activated, right? Whereas if we have, neurons that split and go to their target organs, we can just decrease heart rate. We can just do increased stomach motility. It kind of happens one at a time in your parasympathetic division. It's not as in much communication compared to the sympathetic chain over here. So there's form and function connections there. Now here's how we have to be careful about the cranial sacral division for parasympathetic. And I hate to do this to you, but there is some most recent research that suggests that sacral outflow is exclusively sympathetic. That our whole cranial sacral idea that we've been operating on for the last 30, 40 years is inaccurate. It's probably 100 years. I don't really know how long we've had that idea. It seems it's exclusively cranial nerves that do parasympathetic innervation, and everything sacral region is exclusively sympathetic. And you'll see why later, why we would make that mistake and mix that up. Now, for the time being, everybody you've worked or going to work with in the medical community has been taught this the old way, and I doubt your textbook has caught up. I'll check your new edition. If anybody's got their new edition today, I definitely want to see it and see if they've resolved this issue. I doubt they have. It's brand new information that sacral flow is exclusively sympathetic, not parasympathetic. So I will test you. When I test you on this, it will have the full statement. Cranial sacral, but sacral is under contention and being reconsidered. That whole thing will be on there. So I know this is a complex thing to incorporate new information that's not in your textbook, so you don't have to worry about that conflict in an exam situation. I'm not going to have an exam that's, which division has parasympathetic outflow and have the word sacral on there. That would be cruel and unusual because it's under contention and we're reconsidering it. So does that make sense to everybody? I just don't want you to panic about it. So parasympathetic division, your most important nerve, the one that I want you to carry with you forever and never ever forget, is vagus nerve. And we talked about this when we were talking about cranial nerves anyway. You already know that the vagus nerve does parasympathetic innervation to through the viscera. Everything thoracic and abdominal. The only thing it excludes is some pelvic organs, in fact. So the vagus nerve is going to serve the heart, the lungs, the digestive viscera, the reproductive organs, most of the GI tract. There are some pelvic nerves that serve the GI tract. And again, this is our old understanding. These are the nerves that we used to consider parasympathetic to be serving genitalia and more reproductive organs aside from the gonads. The urinary bladder are served by pelvic nerves, which previously we considered parasympathetic and now are being reconsidered as sympathetic. Vagus is your most important one. If it's an AMP2 and I ask you what innervates that organ, you should just say vagus, because that's your best guess. Pretty much 90% of the time, that's your best guess for if it's parasympathetic innervation. It's actually a fun game. We play in AMP2. Hey guys, guess what parasympathetic nerve innervates the heart? And you all go, vagus! And then we do that again for lungs, and we do it again for the digestive system, and it just keeps going. So it's always vagus. If in doubt, it's vagus. You do have other cranial nerves with parasympathetic functions. Oculomotor, facial, and glossopharyngeal. All right, if you are in fight or flight, what happens to your pupils? Do you need to see more light or do you need to see less light if you're running away from a bear? More light. So sympathetic nervous system is going to cause pupillary dilation. But we're talking about the parasympathetic nervous system right now. So what's that going to do? No, the opposite of what I just said. We're talking about pupillary constriction. Pupillary constriction. Yep. So we just said pupillary dilation for sympathetic, pupillary constriction for parasympathetic. And sometimes that's counterintuitive, right? You don't really think about rest and digest and your pupils getting smaller. So I do recommend that you walk all the way through that logic. Parasympathetic is rest and digest. Sympathetic is fight or flight. If I'm running away from my bear, do my pupils need to be wider or thinner? And then parasympathetic is going to be the opposite of that. As in around. So the sympathetic is thoracolumbar, and previously we said cranial and sacral, so just everywhere else, so around the sympathetic nervous system.
I just wanted to know what the prefix meant.
Yeah, para is around. Like peri, like a perimeter. Yeah. So oculomotor, in addition to pupillary constriction, it's also going to go to the, let's see, ciliary ganglion, ciliary muscle, pupillary constrictor muscle of the iris. I think that's actually it. We're just going to do pupillary constrictor. The facial nerve, you already know that the facial nerve has the function of skeletal motor innervation for muscles of facial expression. The parasympathetic portion of facial nerve is going to go to some of your salivary glands. In fact, it's going to go to two of your salivary glands, submandibular and sublingual. The third salivary gland is known as the parotid salivary gland, and that is served by glossopharyngeal. I'm going to take a step back for just a second. Facial nerve also innervates the lacrimal glands. So when you think of 7, don't think just about saliva, also think about crying and tear production. And there's vagus. The word vagus, V-A-G-U-S, is going to mean the wanderer. That's the actual literal translation of vagus is wanderer. Because if we actually trace it, it wanders all over the place. It branches a lot and it goes to all kinds of things. So those were the cranial nerves. And now we're going to go on to that sacral division, which I'm going to repeat. Now this is under contention. These nerves in our PowerPoint, in your textbook, are considered parasympathetic, but they may actually be sympathetic in nature. We're going to call them pelvic splanchnic nerves. I just like that word, splanchnic. It's a great word. And that's going to serve some of our pelvic organs, such as the urinary bladder, for example. Reproductive organs, urinary bladder, ureter, So urination, micturition, and part of the large intestine, just that last part of the large intestine for defecation. How are we doing with this so far? Am I going too fast? Okay. Now we'll move on to the sympathetic division, and this is generally called the thoracolumbar. It doesn't encompass the entire lumbar region, it just goes to L2. So T1 to L2 is where you're going to find the preganglionic neuron cell bodies that I've illustrated along this line here. And we're going to go back some of that spinal cord anatomy. So recall that you have a posterior funiculus, a lateral funiculus, an anterior or ventral funiculus. You also have a dorsal gray horn and a ventral gray horn. Where did you have a lateral gray horn? In the where? Not lumbar. Well, you'll have it till L2. Mostly thoracic. So in fact, you're going to have it T1 to L2. That lateral gray horn is going to be the location of preganglionic sympathetic neuron cell bodies. So sympathetic preganglionic cell bodies are located in the lateral gray horn. They actually come out ventrally along with those motor neurons, join that ventral root, and then go out along with the same spinal nerves that everything else goes with. So your sympathetic pathways start from T1 to L2, but notice that they're going to innervate things that are superior to T1, like things in your face, and inferior to L2, like your gonads, for example, some aspects of reproduction. So we will have this chain that extends beyond T1 to L2, and some of these preganglionic neurons are going to ascend or descend within the sympathetic chain before they exit. It's part of the branching pattern and part of how they communicate at all levels. So you will have nerves that ascend from T1, and those are going to ascend further up this chain ganglia into your cranium and help with sympathetic innervation to the same salivary glands, the same smooth muscles that control your pupil. So again, look at this. We've got the same organs being served by two systems. They work in parallel to each other. Which means these have to ascend and descend to get to all of their regions. I think your textbook may have preferred the term sympathetic trunk ganglion. I prefer sympathetic chain ganglia. You can see this. This is something that you can see with the naked eye in a dissection. This is the thoracic region, and they've removed the heart, they've removed the lung, and they've removed the parietal pleura to see the intercostal nerves, as well as the sympathetic chain. So each of these little bulging pieces is going to be a ganglion for the sympathetic division of the nervous system. And you can see that they are attached to each other in a chain.
That right there, that's just like that would be like the chain.
This is the chain. Can you see it all up there? Yeah, you can see it pretty well. So there's definitely a ganglion right there. In fact, you can see all the rami. We're going to care about those rami a little bit later. So with this chain, and we're going to go kind of big picture on this, you do need to know about the white and gray ramus, but I'm not going to have you follow too many of these pathways. I just want you to get a sense of how these things can branch and communicate within the chain. So one thing that can happen, we'll have a preganglionic neuron cell body within the lateral gray horn of the spinal cord. And that'll exit via the ventral root, join up with the spinal nerve. But then it's going to go via the white ramus to the sympathetic chain. It's going to synapse onto a postganglionic neuron. And then it's going to leave via the gray ramus, back out a spinal nerve to a target organ. So in via white, out via gray. It actually does like a little loop. It loops around. This white ramus is actually further along the spinal nerve than the gray ramus is. So it comes in, it synapses, it exits via the gray ramus, back out to a spinal nerve and back out to a target organ. That's one option. Another option is that preganglionic neuron, an axon, travels the same basic route in white ramus, and then it can ascend through that chain and then synapse onto a postganglionic neuron, and then that axon goes out to a target organ. It could also descend before making it out of the gray ramus out to a target organ. And if you ever have a hard time understanding these circuits and synapses and in here, out there, connecting at this location, just think of like a subway map when you're learning a subway map, you know? You can get on at the pink line and then you're going to transfer at, let's say, gotta zoom in here, this is the Chicago map. You can transfer at State Street and then you can get onto the brown line and that's then going to take you up to, let's say we're trying to get to Francisco on the brown line. It's just like learning a subway map. We just have really different terminology for it. I don't know if that helps anybody. It helps me to think of it that way.
Someone should make a diagram just like that.
Yeah.
And it would make perfect sense.
You can absolutely try to make the something like that into a subway diagram. It would actually absolutely work. If somebody's done it, let me know. Are you Googling it right now? Good. Okay. So again, I'm trying to get out to the target organ, so I get on the train station at the lateral gray horn. That's going to go through a loop, and it's going to travel to an inferior sympathetic chain. I'm going to get on transfer to another bus or another train, so I'm just going to synapse, and then that second train is going to take me to the target organ. That's all we're saying right now. Might have made it worse just then. I don't know. It made more sense. Yeah, in white ramus, out gray ramus. So it may come in at a white ramus on one level and out a gray ramus at a different level. And when we say white and gray, we literally mean white and gray. White matter has myelin. The gray ramus, it's still axons, but it's unmyelinated axons. And it's physiologically unmyelinated. It's just going to be a little bit slower. Just in that little tiny patch right there. So that's sort of our standard pathway for most of our thoracic region. We do have a couple of other routes that it can take. They all do go through that sympathetic chain. We have at least one that does not synapse within the sympathetic chain, and they may use Splanchnic or other ganglia in order to reach their target organ. We do have a direct pathway in white ramus and actually out of a Splanchnic nerve straight to the adrenal medulla. Do you guys remember? Oh, we haven't done endocrinology yet. So does anybody happen to know what's going on with the adrenal medulla? Maybe past experience? What our adrenal glands are about? No. Our adrenal glands, our adrenal medulla specifically, the middle part of our adrenal glands, are going to release epinephrine and norepinephrine. And those are going to be two hormones that increase the activities of the sympathetic nervous system. So what's significant about this is having one neuron go straight to the adrenal medulla. That's going to increase that level of epinephrine and norepinephrine. Those are also known as adrenaline and noradrenaline. Those are the same things. You've probably heard of adrenaline before.
So that's why when you are like in that fight or flight,
Mm-hmm.
so you have this adrenaline rush,
Yes.
and to be able to do those.
Absolutely. So fight or flight, adrenaline rush. So we do have that, I call it the panic button. It's the mini panic brain of the abdomen, and it releases that epinephrine and norepinephrine. So even though you do have these nerves directly innervating things and causing things like increased heart rate, you also have hormones circulating at the same time that increase all of those activities. It's part of that all hands on deck thing that has to happen with the sympathetic division. If we're going to run away from a bear, it's got to happen right now. We can't wait on it. Yes, Jenny? The difference between epinephrine and norepinephrine, and this will become significant to you at a certain point, is called receptor selectivity. They both increase activities of the sympathetic nervous system, but some types of receptors will bind more to epinephrine, and some receptors will bind more to norepinephrine, and that's really the only difference. Which receptors they bind to. Because one day, and I think it might even start today, you're going to need to know about alpha and beta receptors, alpha 123, beta 12, receptor subtypes, their locations, their activities in all of these different locations. The more you can learn about that now, the less you'll have to memorize when you get to pharmacology and you start talking about different types of beta blockers and alpha blockers and things like that. So it really does keep playing out. That stuff's important.
So why do we get adrenaline from good or exciting things?
We do get adrenaline from good or exciting things.
But why?
Absolutely.
If that's part of like the fight or flight.
Oh, gotcha. Because we call it the fight or flight system, but it's always acting on us in different ways. So if your pupils need to dilate, even if it's not because you just ate a burrito, it's not necessarily because you're resting and digesting. It could be about light conditions. It could be high light condition. It's still going to use that parasympathetic nerve to do it.
Okay. So it's just the same category. It doesn't necessarily always have to be fight or flight.
Absolutely.
It doesn't. Okay.
Yeah, it's just if we want to increase our heart rate, we're going to use a sympathetic nerve to do it.
Okay.
Yep. And that absolutely has fallout in terms of some stuff. We'll talk about it later. Some of these nerves participate in plexuses, and I don't think I really want to go beyond that. So you need to know where some of these plexuses are. Luckily, this is very intuitive. I don't think anybody's ever had a hard time catching on to which plexus is which, because the cardiac plexus gets what that is going to control. Probably your heart. And your pulmonary plexus, probably your lungs. Esophageal plexus, yeah, probably your esophagus. Now this one's the only place where you might get caught a little bit. You're going to see these terms a lot in AMP2. Celiac, superior mesenteric, and inferior mesenteric. You're going to see a celiac trunk. You're going to see a superior mesenteric artery and inferior mesenteric artery. They're a pattern of arteries that come off of your abdominal aorta. And what's a huge thing? Yeah, the aorta is gigantic for sure. So the celiac plexus is going to, all of these are going to serve digestive organs. Celiac plexus, specifically liver and stomach. Superior mesenteric, specifically small intestine and actually most of your large intestine too. Inferior mesenteric, distal colon, basically, the last part of your large intestine. And really, for now, all you need is digestive viscera. Gesundheit. Okay, and then hypogastric, you know where the hypogastric region is. So it's going to be sort of pelvic splanchnic nerves, pelvic region. It's a little bit early, but I kind of want to take a break here. Back from break, and I want to point out that the big danger here is overthinking for the sake of the recording, and definitely on this topic right here. Overthinking is really dangerous on this, what we're about to say. Because what we're about to say is really not that complicated. You're just not used to learning the names of receptors yet. So, your parasympathetic pathway, the preganglionic neuron is going to release acetylcholine. and that acetylcholine is going to diffuse over onto the cell body or the dendrites of the postganglionic neuron, and it's going to have a type of receptor known as a nicotinic receptor. Now, why do you think we might have named it a nicotinic receptor? Nicotine. Nicotine is going to also act on this receptor. So sometimes receptors are named after drugs that act on them. And that's the only significance here. Preganglionic neurons, acetylcholine onto nicotinic receptors on the dendrites of postganglionic neurons. And that postganglionic neuron is also going to release acetylcholine, but the target cell is going to have a receptor called a muscarinic receptor. Has anybody ever heard of muscarine before? Muscarine? So if you were to do a Google image search for muscarine, one of the things that would pop up is a mushroom. It looks kind of like the mushroom in Mario that makes them get bigger. In real life, it's a poisonous mushroom, and if you eat it, you will die, because it's going to activate this pathway, and it's going to slow everything down, just like your parasympathetic nervous system. But actually, it's going to shut things down, and you're going to slip into a coma and die. So don't do that. So it's named after muscarine, the substance that also, the drug that also binds to it. And again, all you need to know here, preganglionic acetylcholine onto nicotinic, postganglionic acetylcholine onto muscarinic. That's it. Don't overthink it. That's all I'm asking. Sympathetic, you'll notice there's two options. One of those options is identical. So this is going to maybe give you some information about why we mixed up that sacral outflow and said it was sympathetic, or parasympathetic rather than sympathetic, and why that we're rethinking that now. That's not all of it, but that's a big part of it. So when you think of a sympathetic pathway, I actually just want you to think of this one right here. Preganglionic neurons release acetylcholine onto nicotinic receptors. That's the same. But postganglionic neurons release norepinephrine onto adrenergic receptors. So recall that norepinephrine is the same thing as noradrenaline. So now we have an adrenergic receptor. It responds to adrenaline type things, right? That's where the naming convention came for with that. So one more time just to reinforce it. Parasympathetic pathway, acetylcholine onto nicotinic, acetylcholine onto muscarinic. Sympathetic pathway, acetylcholine onto nicotinic, norepinephrine onto adrenergic. And on your worksheet today, I may have something like alpha and beta adrenergic, or alpha and beta receptors. It means the same thing. So there are going to be different types of adrenergic receptors. We're going to call them alpha adrenergic or beta adrenergic. And that vocab's going to carry forward for you for pharmacology. Alpha blockers, beta blockers, yes?
And the stuff for the lab principle, is images in there? Would you, how would you test this?
I think I mostly just gave you the image because it's a good image to practice for the lecture exam content with. I don't know that there's really anything on your list for the lab practical. No. Yeah. There are a couple of us that are, a couple of images on the lab practical images that are like that, yes. I get asked that every semester. One day I'll go in and we'll clean up the pictures, but you can use them to practice for the lecture exam. They're not harmful to have blanks of. Okay, so all preganglionics release acetylcholine, generally onto nicotinic. Postganglionic are different between sympathetic and parasympathetic. I'm not going to have you learn the entire table right now. I have a couple of things on your worksheet that I want you to focus on for these. And I think in your vocab list, you guys saw the vocab list, right? Posted a vocab list for this. And that has some very specific receptor subtypes. That having been said, quarter 4 is going to be a really big challenge for you. So if you memorize all of this right now, that's going to be easier in quarter 4 when you're actually studying the pharmacology of this. Because you are going to have alpha 1 receptors, alpha 2 receptors, beta 1, beta 2, and beta 3 receptors, and blockers, and agonists and antagonists. So just zooming in on a few of these, and this goes to that question we had earlier, what's the difference between epinephrine and norepinephrine? Most of these prefer to bind to norepinephrine. Only beta 2 receptors prefer epinephrine on this list. So beta 2 receptors are going to be found in heart arterioles, in the bronchi of the lungs. Those are your airways of your lungs. Your liver, your skeletal muscles, your arterioles. Beta 1 receptors are going to be found in your heart. Beta 3 receptors are going to be found in adipose tissue. So when you're running away from a bear, you may get energy from your fat stores. It's right there. So lipolysis means we're breaking down fat for energy. Alpha 1 receptors found in your guts, in your reproductive and urinary structures. So you can see the effects over here. And again, I'm not going to have you rote memorize everything. I'm not going to test you on everything. Focus on what's on the vocab list and on the worksheet. But if you can start learning this now, it's going to make your life easier later. Yes, Jenny? Epinephrine is the preferred one to bind on beta 2 receptors. Yep. Again, when we talk about moving forward into pharmacology, these are some things that you do need to learn today. Agonists and antagonists. Have you guys ever heard of antagonists and agonists in the context of drugs before? So you've seen it in terms of muscles, and it basically means the same thing. The agonist is doing the thing. The antagonist is working against the thing, right? That's absolutely what we're going for. So the muscarine is an agonist for the muscarinic receptors, which means it's going to increase the activity or mimic the activity of the parasympathetic nervous system on whatever target organ has that receptor. Nicotine is an agonist for the nicotinic receptors, which means it's going to act to increase the activity, and remember this is both in sympathetic and parasympathetic nervous system. So if you do get a little bit of a drug effect from smoking cigarettes, cigarettes are a drug. It's not even under contention. It's absolutely a thing. Phenylephrine is an agonist for alpha adrenergic receptors. Isoproterenol is a beta adrenergic agonist. And the opposites are over here. Atropine is going to be a muscarine antagonist. And antagonists can work in a variety of ways. We're not going to do all of the pharmacology today. We're not going to say, every single detail of this, but there are a number of different ways agonists can work. They can block the receptor without activating it, for example. And if it's blocked, that means the normal thing can't bind to it. So atropine would be a muscarinic antagonist. Alpha bungarotoxin will be a nicotinic antagonist. Alpha blockers will be alpha adrenergic antagonists. And beta blockers like propranolol will be beta adrenergic antagonists. So yes, you are responsible for that today. All right, just wrapping it up. That was the hard stuff. We already finished it. And we've covered this concept before. Everything has dual innervation. So your pupils will have a parasympathetic nerve coming to them. They will have a sympathetic nerve coming to them. And depending on the situation, one will act over the other, right? So the parasympathetic is going to cause pupil constriction, whereas sympathetic will cause pupil dilation. And it's going to work the same way for every system, for every organ. Your heart will have a parasympathetic nerve and a sympathetic nerve. If you're wondering why we need to clarify that at all, probably for a lot of systems, we started from the idea that, a neuron would fire to do something and then just stop firing to stop doing that. So that would be something that could potentially be true, but for the most part, we find that it's like one neuron fires and then another one inhibits that one, or does the opposite of that one, to actually cause changes to your nervous system. That's the more likely answer. And we've covered this idea before. This is just to reinforce that idea that we call it fight or flight, we call it rest and digest, but if your pupil needs to be constricted for another reason, we're still going to use that autonomic nerve. We're still going to use autonomic innervation to do it. So they're always in balance and they're always acting on you. Your autonomic nervous system is acting right now, even though you're not necessarily digesting a burrito or running away from a bear. You're just sitting here. They're both acting on you anyway. You're just more in balance right now. Autonomic reflexes, this is just sort of a tie-up concept where the central nervous system is going to act on your autonomic nervous system via the hypothalamus specifically. That's actually our last concept of the day. But some of these act via reflexes, and a good example of that is micturition. It is entirely visceral sensory neurons coming back, sensing bladder distension, coming back to the spinal cord and innervating or synapsing onto autonomic neurons that then go out via autonomic nerves to cause micturition. So urination is a reflex, and it's an autonomic reflex, as opposed to the somatic reflexes that we learned about last week, where that's conscious stimuli affecting general sensory or somatic sensory neurons and innervating onto skeletal motor neurons. So it's the same reflex idea, it's just different nerves acting on it. Visceral sensory as opposed to somatic sensory, autonomic as opposed to motor or somatic motor. That make sense? Okay. So your autonomic function, when it's not acting purely as a reflex, it will be influenced by the central nervous system, by the brain specifically, including the cerebrum, the brainstem, and the spinal cord. That should say spinal cord, not spinal cord. But I want you to mainly focus on the hypothalamus. So for today, the hypothalamus is going to be the region that commands everything that is unconscious, and that includes the autonomic nervous system. This is the command center for autonomic functions. It even says so right on the package, right? When we start AMP2, we'll do endocrine system, and we will see then that it is also controlling the hormones of your body, but for now, the hypothalamus is about the autonomic nervous system control. And that's it. Any questions before I turn off the recorder?
Is it possible to have things wrong with your hypothalamus?
Oh yeah. Super possible to have things wrong with your hypothalamus. In fact, in a second, I'll show you some knockout mice. So it is controlling all of your unconscious things, and it's getting sensors for all of your unconscious things. So for an example, a prime example of this, we have a center that knows how hungry we are, which is to say what our blood sugar level is, and then can enact feeding behaviors. So some of these are behavioral, not necessarily just entirely like chemical control, right? So we have these things called knockout mice. We knock out that part of the brain of the hypothalamus that controls feeding behaviors or sensing the blood sugar levels, and then we get obese mice. It's absolutely a thing. They're really adorable. They're just like little spheres of mouse. They're so cute and sad. But yes, that's absolutely a thing. You could have a brain injury that would hurt your hypothalamus. You could have a tumor that would hurt your hypothalamus. And any one of the behavioral or chemical control or internal and autonomic functions can be, that you can have problems to any one of those. If it heads to like a respiratory center or a cardiac control center, you're in a lot more danger. But obviously, feeding and drinking behaviors are also important. You can have, yeah. Absolutely.
Could you have someone like drink so much water that they like drown?
Yes.
Overhead?
Yes.
So would that be like a hypothalamus problem as well?
Related, yes. We're actually going to see specific diseases related to like people drinking literally too much water. Mm-hmm. No, you can drink water. You can drink too much water to death. Absolutely. Hyponatremia. Yeah.
So if someone were to be morbidly obese because they eat so much, is it possible to go in there into the hypothalamus and make them not eat as or not drink?
It's a really good question, and it's absolutely an avenue of research. But the avenue of research you're talking about is repairing damage to the central nervous system. And we know from our Wallerian degeneration lecture that the central nervous system, those axons do not like to grow back. So it's a big avenue of research. Can we get those axons to regrow? Can we remove a tumor and then repair that area and then restore that function? And so far, that's a big no. There's some correlates. There's paralesional activation. The more you can activate the brain areas around it, the better the recovery outcome for like physical therapy contexts. But no, we don't currently have a way to fix that. We're working on it. Everybody's working on it. If we could reverse brain injuries, we'd be a much better place, a much happier society. Okay, any other questions? Those are fantastic research-based questions.
I've lost it, but you can turn it around.
Okay, we're turning the recording off now.